Today, we're diving into a heart medication called Ivabradine. Now, this one's interesting because it's not just about treating symptoms, it's about rewriting the very rhythm of a struggling heart. Think of it as a precision tool for a problem that standard treatments sometimes just can't solve. So, have you ever thought about what happens when the heart's own rhythm actually starts working against it? For some people with chronic heart failure, that's exactly the problem. Their heart just beats too fast, all the time, even when they're resting. And that puts this dangerous, constant strain on an already struggling muscle, even when they're on all the standard treatments. All right, so let's start by digging into the core problem here. When we talk about heart failure, a high resting heart rate isn't just a side note or a symptom. No, it's a major risk factor that's actively making the condition worse over time. Think of it like this. Your heart needs time between beats to fill up with blood, right? That's called the diastolic time. Well, when your heart is racing, that filling time gets cut way short. So every pump is less efficient, which forces the heart muscle to work overtime. It's not sustainable, and it leads to more damage. And this problem is especially critical for a very specific group of patients. We're talking about people whose hearts are already significantly weakened. Their resting heart rate just will not dip below 70 beats per minute, even when they're on the absolute maximum dose of standard meds like beta blockers. They're basically stuck in this high-risk zone, and that's where we need a different approach. Okay, so how does Ivabradine tackle this problem so precisely? This is what's so cool about it. Unlike some of the broader medications out there, it acts more like a surgeon's scalpel, not a sledgehammer. It targets the very, very source of the heart's rhythm. So to really get how Ivabradine works, we first have to take a quick look at the heart's own control center, the sinoatrial node, or you'll just hear it called the SA node. This is your heart's natural pacemaker. It's the tiny cluster of cells that sets the rhythm for every single beat. Now, inside that pacemaker, there's a very specific electrical pathway. It's called the IF current, but it has this great nickname, the funny current. And this funny current is the key regulator. It's basically the little dial that tells the SA node how fast or slow to fire. It directly controls your heart rate. And this is where the precision of Ivabradine really shines. It selectively goes in and blocks that funny current. What does that do? It slows the pacemaker's firing rate, which lowers the overall heart rate. But here's the absolute key. It does all of this without weakening the heart's actual pumping strength, its contractility. That's a huge deal. So if you put it side by side with something like beta blockers, the difference becomes crystal clear. Beta blockers, they're a first-line therapy, and they're great. They lower heart rate and blood pressure, but they also have an effect on the strength of the heart's contractions. Ivabradine, on the other hand, is purely a heart rate-lowering agent. It's designed to be used as an add-on therapy, specifically when beta blockers alone just aren't getting that heart rate down enough. Okay, so a unique mechanism is great in theory, but the real question is, does it actually help patients? Well, the answer lies in the clinical evidence, and specifically in a landmark trial that really put Ivabradine to the test. The big study we're talking about here is called the SHIFT trial. And this wasn't some small thing. It was a massive, really high-quality study designed to see if adding Ivabradine to standard therapy for heart failure patients could actually improve their outcomes. And this number right here, 70 beats per minute, was absolutely key. The trial specifically went out and recruited patients whose hearts were stuck in that high-risk, high-rate zone, even with all their other treatments. So this was a direct test of the drug's core purpose. Could it help these people? So what did they find? Well, the results were pretty significant. The patients who took Ivabradine saw a really notable reduction in how often they were hospitalized because their heart failure was getting worse. To put it simply, the drug was proven to keep these high-risk patients more stable and, crucially, out of the hospital. But, of course, as with any effective medication, there are always risks. It's not a magic bullet. So to use Ivabradine safely and effectively, it is absolutely essential to understand the potential side effects and, just as important, what it shouldn't be mixed with. So the most common side effects are, not surprisingly, directly related to what it does. Bradycardia, which is just a heart rate that's too slow, is a key one to watch for. It can also increase the risk of an irregular heartbeat called atrial fibrillation. And then there's this very unique side effect that has to do with your vision. Yeah, this is known as luminous phenomena, or phosphanes. What does that mean? Well, patients might see temporary bright spots or halos, maybe flashes of light,
especially when there are sudden changes in brightness. And it happens because ivabradine can also affect similar electrical channels in the retina of your eye. The good news is, it's usually mild and often just resolves on its own. Okay, so beyond side effects, we have to talk about interactions. This is so important because what you eat, what you drink, or even supplements you take can dramatically, and I mean dramatically, change how this medication works in your body. Okay, I want you to think of an enzyme in your body called CYP3A4. Think of it as your body's dedicated processing crew for ivabradine. Now, some things, like grapefruit juice, believe it or not, they block that crew, and that causes the drug to build up to dangerous levels. Then you have other things, like the herbal supplement St. John's wort, that put the crew into overdrive, clearing the drug out way too fast and basically making it useless. All right, so with all this knowledge of the benefits and the risks, how do doctors actually decide who is the right patient for this therapy? Well, it really comes down to a clear and pretty strict set of guidelines. Yeah, the do not use list is very, very clear. Since the whole point of the drug is to lower heart rate, it's completely off limits for anyone whose heart rate or blood pressure is already too low. It's also avoided if someone has severe liver problems or if they rely on a pacemaker, because these conditions just interfere with how the drug works safely. And dosing isn't a one-size-fits-all kind of thing. It's actually a pretty dynamic process. Doctors will start with a low dose and then adjust it every few weeks based on the patient's resting heart rate. They're trying to hit that sweet spot, right between 50 and 60 beats per minute. And all of this brings us to the most important takeaway. Ivabradine is not a replacement for those foundational therapies like beta blockers. Not at all. It's a specialized tool. It's an add-on therapy that's used only when controlling a stubbornly high heart rate is the main challenge left on the table. Ivabradine's super-focused mechanism really highlights a bigger shift we're seeing towards more personalized medicine in cardiology. By targeting a very specific problem, that funny current, it offers a truly tailored solution. And it leaves us with a really interesting question. What other precise targets like this might we find to fine-tune heart failure care in the future?